Peter Pytel has been in the pathology department at the University of Chicago since 1999, initially as a resident and fellow, and since 2005 as a faculty member. Most of his time is dedicated to clinical work on the neuropathology service as well as the bone and soft tissue service. And I'm looking forward to this talk.
Thank you. Good morning, everybody. And I'm excited about the opportunity to talk about peripheral nerve biopsies. I hope everybody can see my screen and hear me. I have one financial disclosure that I am served on the advisory board for Severe Pharmaceuticals. These are the learning objectives for today's sessions. I will talk about common reasons and indications for clinicians to order peripheral nerve biopsies. I will spend a good deal of time on talking about the morphologic features that we see in vasculitis affecting peripheral nerves. And then I also talk about some more unusual diseases and the way they may be associated with distinctive morphologic findings that can offer a helpful clue to us in making a diagnosis. Up front, I just wanted to kind of remind all of us that as neuropathologists, we may have a somewhat biased view on the topic of peripheral neuropathy. It's a very common disease, especially in the elderly population, where 7 to 8% of individuals may be affected. Many of the patients that have peripheral neuropathy are seen and managed by the primary care physician. Common etiologies include metabolic diseases such as diabetes, toxic problems like alcohol use, or complications of medications that the patient receives, for example, chemotherapy drugs. The workup usually may include detailed history, physical exam, hemoglobin A1C, vitamin B12 levels, metabolic panels, TSH, serum protein electrophoresis. And only a subset of the patients with peripheral neuropathies are referred to a neurologist, usually if there are any atypical features. And of those patients that go to a neurologist, only a small selection may eventually wind up having a peripheral nerve biopsy. So what are indications or reasons for the clinicians to ask for a peripheral nerve biopsy? Usually it's that the patient has a progressive cryptogenic polyneuropathy and usually a more acute or subacute time course. Sometimes the nerve biopsies are submitted with a specific clinical question. For example, does this patient have vasculitis? Does this patient have amyloidosis? Maybe rarely these days, but does the patient have an underlying infection that causes the presentation? There are a number of studies, like the ones that are cited here at the bottom, usually single institutional studies that basically review the findings in nerve biopsies that were reviewed at that one institution over a long period of time. Obviously, these kind of studies often have to be taken with a grain of salt. Not that there's anything wrong with the study itself, but referral patterns, practice patterns may vary the way the local clinicians use peripheral nerve biopsies as a tool may vary from institution to institution. And so the numbers that these studies provide may not be exactly accurate for your own place of practice, but I think they still offer some useful guidelines. On a descriptive level, common reported findings include the finding of axonal loss, the finding of ongoing active axonal degeneration or Wallerian degeneration, vasculitis in about 9% of the cases, amyloid in about 3% of the cases, the presence of a vessel instead of a nerve in up to 4% of cases. In my own anecdotal experience, I see that, I'd say it's less than that. But and then there are rare conditions. I listed just lymphoma here as one of those that's seen in less than 1% of cases. And about 17% of cases in these studies were listed as being at the end morphologically normal. When we think about specific indications that led to the nerve biopsies, then patient that had a nerve biopsy for a question of vasculitis wind up having vasculitis in about 60% of cases. Those where the initial question was whether the patient has amyloidosis wind up having a positive finding in about 40% of the cases. My biggest disclaimer for this talk maybe is that that there really isn't, I think, a very uniform way in which people approach peripheral nerve biopsies, in which they, in the way that they process these, and the way that they use specific special stains, and in the way they report these. And I think the last consensus study that I could find is from 2010, and I like this sentence that they have in the discussion, that there's very little high-quality evidence available for the usefulness of specific methods in a nerve biopsy workup and evaluation, and that this is in contrast to a large body of expert opinions and experience. So everything that I say you can take with a grain of salt, and if you talk to other people that look at a lot of peripheral nerve biopsies, they may have somewhat different practice patterns. But I hope that you still find useful what I will present here. Stains, so usually when we get nerve biopsies here, we basically triage the specimens and divide it up, having alternatingly pieces processed for paraffin embedding and EPON embedding. We basically never freeze tissue for IF studies, and over the years have also essentially stopped doing teeth fiber preparations. Routine stains include the H&E and the Congo red stain that we do on all cases, as well as the semite and EPON sections that we examine on all cases. I very liberally use CD3 and CD68 staining, also the trichrome stain. And then as needed, add additional studies, electron microscopy, some other IHC stains, really maybe some other special stains like an elastic stain to better look at vessels in the nerve biopsy. And just to kind of look at what we might then get on a nerve biopsy and how I approach looking at these. So my own personal preference is to look at the nerve biopsies and cross sections, and I know that people will disagree with that. I find that looking at the cross-sectional profiles of the fascicles makes it easier for me to interpret any changes. And since often we are looking for changes in the blood vessels, I also find it easier to examine those on the cross sections. Those run in parallel with the fascicles. And so if I look at cross sections of the nerve, usually I get to see the cross-sectional profile of the nerve. I try to assess whether the length of the nerve is what I'd expect. Other people may have experienced something similar, but I feel like the nerve biopsies tend to get shorter and shorter, and sometimes I get this piece of tissue that's less than a centimeter in length, which maybe sometimes raises some issues about how representative the section can be of a peripheral neuropathy that may be caused by a process that can go along with just segmental changes, so those and diffuse changes throughout the length of the specimen. And because the length is partly obviously determined based and documented in the growth description, but if you have several cross-sectional profiles, that also is an indication that you had a good length of specimen. Then I try to assess whether the nerve that I see at low power seems to be appropriate for the anatomic site that the surgeon provided for the target of the biopsy. Most of these biopsies are obviously from the sural nerve, and usually with the sural nerve biopsy, I'd expect to see several fascicles, as we see here. And then to kind of at low power, I try to assess whether I see any inflammatory infiltrates, if there are any, where they are found, so whether in the epineural compartment, the connective tissue between the fascicles, whether they are associated with the larger epineural blood vessels, or whether inflammatory changes are found within the endoneural compartment within the individual fascicles. Other changes to look for on the H&E and the trichrome stain obviously would be whether there's any amyloid deposits. Especially in the specimen is well preserved, you may already get a good idea on the H&E stain about the state of the axons and how well the large myelinated axons are preserved. In this particular example here, the nerve looks relatively normal as far as I can tell here. And obviously then we go next to look at the EPON sections. That will take a little bit longer to be completed. On the EPON sections, we again can look at low power, whether the appearance matches that of the H&E stained slides. And then we can look at whether the density of the large myelinated axon that we see as a little donut-like structures are what we expect, and or whether there's any loss of the large myelinated axons. And if there is loss, then as a follow-up question, we can ask whether that loss is uniform throughout the biopsy, or whether we see some variation either within or between the fascicles that were sampled. And then at higher power, we can look at other details of the myelin morphology, whether the thickness of the myelin sheath appears appropriate for the diameter of the associated axon, or whether we have any abnormally thin myelin sheaths. We can look for any features of ongoing axonal degeneration with unraveling of the myelin sheaths. We can look for onion bulbs. And then sometimes we have to deal with artifactual changes, as we see here, that are likely related to crush artifacts from the handling of the biopsy, either during the procedure or during the triage in the growth room. So these are kind of the general questions that we just went through on the slides that I tend to ask myself when I look at the nerve biopsy. And with that, I want to come to our first case. This was a 65-year-old that presented with bilateral foot pain. The pain developed over a relatively short time period of 5 weeks and was associated with some numbness. And it impaired the patient's abilities to walk and to exercise. And so the patient had a nerve biopsy. One additional piece of information that I did not include in the slides that were available for preview were that the symptoms started after several cycles of immunotherapy that the patient received for a diagnosis of mesothelioma. And so when we look at this biopsy here, we can see at low power that this looks like a specimen that probably was a good size length. We have several cross-sectional profiles. We see a number of fascicles per cross-sectional profile. So this looked appropriate for a sural nerve biopsy. And so then even at low power, you already start to see that there are areas of increased cellularity that look like they are cellular infiltrates. And if we look closer, we see a number of changes. We see vessels with features of fibrinoid vessel wall necrosis. In the backup, maybe some neovascularization with a bunch of these little small blood vessels that sometimes result in almost hemangioma-like pattern in the background of larger occluded or damaged blood vessels. We see vessels that are recanalized, where we can make out the smooth muscle cells at the periphery of the pre-existing vessel. And then within that, we have occlusion that contains multiple smaller vascular lumina. See here a vessel with more recent thrombotic occlusion. Then we have vessels with somewhat more chronic fibrosing changes, as we see here, where the lumen is obliterated. And where you might also argue that there's probably some loss of the smooth muscle cells here of the media, and we see more smooth muscle cells here and essentially a complete loss of these smooth muscle cells here at the bottom. Sometimes a helpful stain, especially when we're thinking about dropout of smooth muscle cells from larger vessels, can be a smooth muscle actin that can just confirm that the normally complete ring of smooth muscle cells around a vessel is disrupted. Here's another vessel with similar changes, occlusive changes, dropout of smooth muscle cells here to go along with some scarring of the vessel wall. These are just the still images that kind of basically recap what we just reviewed. So we have some inflammatory infiltrates. We see some fibrinoid vessel wall necrosis. We see some acute occlusive changes with thrombotic features. This vessel, we see combination of changes where we have some recanalization as well as these fibrinoid vessel wall changes. Some recanalization of a more chronic occlusion, and then these more chronic thrombotic occlusions with dropout of smooth muscle cells. So the basic diagnosis that I rendered in this case was one of active vasculitis. Details that I'd like to include in my comment when I report on a vasculitis is the size of the affected vessels. So for that, I usually get the micrometer out that I otherwise use to measure the depth of the melanomas I sign out. And so in this case, the affected vessels were the larger epidural vessels between 50 and 300 microns in diameter. Another comment I usually like to make is whether I see any distinctive features within the pattern of the inflammation. And usually the two main ones would be whether there are granulomatous features or whether the inflammation includes prominent eosinophils. Other comments would be whether we see any amyloid deposits on the Congo red stain. The amyloid stain in this case was negative. The EPON sections were still pending, but this is a diagnosis for which I call back the clinicians and provide them the diagnosis just based on the paraffin sections. So usually with a day or two of the biopsy, so that they can go ahead and start treating the patient as appropriate. In the context of this particular history, then I would suggest that this is likely a presentation of a systemic vasculitis that is secondary and related to the immunotherapy that the patient is on. So when we think about vasculitis in general, I guess in medical school and in our textbooks, we learn about the classification of different types of vasculitis based on the diameter of this involved vessels. I guess when we mention the size of vessels in the nerve biopsies, we just have to keep in mind that the vessels that are large in the context of the nerve are still small vessels in the world of vasculitis. So the larger epineurial vessels that are typically between 75 and 300 microns are small vessels when we talk about the classification of vasculitis cases. And so when we think about vasculitis involving the nerve, we can have cases that either involve larger epineurial vessels, as the case that we just discussed, or we can have cases where the microvessels are affected. The cases affecting the larger epineurial vessels are usually cases of systemic vasculitis. And within that category, we can distinguish those that are primary and those that are secondary. Primary cases would be examples like polyarteritis nodosa, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis. Or cases of secondary systemic vasculitis would be those, for example, that are related to drugs that the patient is on, as in our case here, likely, or where the presentation may be the result of paraneoplastic disease process. Vasculitis with involvement of the small vessels is typically related to patients that suffer from a non-systemic vasculitic neuropathy or NSVN. And we'll come back to that in a second. Typical clinical features for those patients presenting with vasculitis are that they usually have painful sensory or mixed sensory and motor neuropathy. Usually the presentation is acute or subacute. And I guess not always, but sometimes individual nerves may be sequentially affected, resulting in what we describe as a mononeuritis multiplex type presentation, where maybe the patient initially presents with a wrist drop, later maybe develops a foot drop on the other side. So it's kind of asymmetric pattern of involvement. Cases of systemic vasculitis tend to be more permanent and acute than those of non-systemic vasculitis. Often the patient obviously has features of organ involvement. Those could include a rash, GI symptoms, respiratory symptoms, hematuria. And more often, those are also the types of vasculitis that might go along with some constitutional symptoms like fevers, chills, night sweats, and weight loss. The general workup for a patient with suspected vasculitis would include the CBC and the metabolic panels, basic inflammatory markers like the ESR and the CRP, as well as some basic rheumatologic studies, including the ANA, rheumatoid factors, hepatitis, cryoglobulins, and then this testing for the anchor antibodies. The next case I just wanted to show very briefly to make one additional point. So if you look at this nerve biopsy here, we again see similar features as to the one in the first case discussed, where we have extensive inflammation within the epineural compartment. The inflammation seems to be centered on these larger epineural blood vessels. again, we see that the inflammatory cells infiltrate the walls of these vessels, that there are occlusive changes of these vessels. As an additional feature, though, in this case, you can see that there's prominent eosinophils in the background. So this patient, on further review of the chart, was found to have peripheral eosinophilia, asthma, nasal polyps. And so in this particular case, as a morphologic hint with the eosinophils suggests this patient would fit for having a presentation of eosinophilic granulomatosis with polyangiitis. Other features we may be looking for on a nerve biopsy in the patient has vasculitis would be asymmetry in the pattern of axonal loss. So in this particular example here, we see that the density of large myelinated axons is much larger in some of these fascicles and lower in this fascicle. So we might see variation either between or also sometimes within the fascicles and the density of the axons. And that can be at least a soft sign that could point towards a vasculopathic process, and usually that means vasculitis. With that, I get to the second case that's still kind of related to the topic of vasculitis. This was a 59-year-old that presented with weakness. And so if you look at this nerve biopsy here, the biopsy may be slightly thinner than the other ones I've shown, but still looks okay. Maybe for a somewhat more distal sural nerve, we see several distinct fascicles. And at low power, this nerve biopsy looks fairly unremarkable. Maybe here and maybe here, there are some subtle lymphocytic infiltrates around the vessel. This is the focus that I'll show on the next slide. So based on the findings in this initial H&E level, I ordered some deeper levels. And when we look at the same focus here on the deeper levels, we see how the same vessel that we saw before here is basically destroyed and obliterated, and how we see kind of thrombotic changes in the obliterated blood vessels to suggest that there's vasculitis here affecting the smaller blood vessels in the epidural compartment. So again, these are the still images that kind of just show the low power appearance of the initial H&E that shows these perivascular somewhat scanned lymphocytes on the initial level. And these are the findings of that same vessels on the deeper levels. So based on this, we can still make a diagnosis of active vasculitis, but in this particular case, it seems to be the smaller vessels that are affected. Not that we can make this as a definitive diagnosis just based on looking at the biopsy, but as I mentioned before, vasculitis affecting these smaller vessels is often associated with non-systemic vasculitic neuropathy. Obviously, then that would be a question and discussion with the clinician. So my favorite special stains on peripheral nerve biopsies is ordering deeper levels. I find that very useful, either when I just see subtle inflammatory changes and I want to make sure that there isn't anything more that's hiding deeper in the block, or if I see subtle vascular changes and I want to see whether maybe those declare themselves on deeper levels, or sometimes even if I don't see anything, but I have a history that raises a question of an inflammatory process or vasculitis. And it's surprising how often I find additional informative features on the deeper levels that were not apparent on the initial H&E levels. For a diagnosis of vasculitis, we have helpful features. Down here is a reference for those from kind of a consensus paper. So the diagnostic criteria for vasculitis includes inflammation in the wall of the vessel, so not just perivascular inflammation, but actually inflammatory cells within the walls of affected blood vessels. And in an active lesion, that mural inflammation is associated with features of active wall damage. That can be fibrinoid necrosis, as we saw. That can be disruption of the endothelium. That can be loss of fragmentation of either the internal elastic lamina or the smooth muscle cells, or it can be thrombosis of the lumen. In a chronic lesion, these inflammatory changes on the wall are associated with features of chronic vascular damage. So intimal hyperplasia, fibrosis of the media and the adventitia, thrombosis with recanalization. And an important side note here, one should exclude other disease processes like lymphoma or amyloidosis when making this diagnosis. There are also criteria for a diagnosis of probable vasculitis. These include that we see predominantly axonal damage in the nerve biopsy, and that feature of axonal damage is associated with either perivascular inflammation with acute or chronic wall damage, or perivascular inflammation plus some other features that include hemosiderin deposits around the vessels, asymmetric multifocal axonal loss, as we saw in that one image earlier from an EPON section, or prominent active axonal loss. As a side note, I just mentioned that I don't hesitate to at least more vaguely mention the possibility of vasculitis, that there see inflammatory changes, maybe associated with some other soft findings where I feel like I can't make a definitive diagnosis, but I also still want the clinicians to consider that that's at least an option, and that they should maybe address that option by the additional testing that they order. Also, another side note, I showed the case of the small vasculitis, and I often find these criteria harder to apply in cases where the vasculitis involves potentially the smaller rather than the larger vessels, because the features of vessel wall damage are just more difficult to document. If the vessel to begin with only has like 2 or 3 layers of smooth muscle cells, and it's overall a small vessel where it's just not obvious that you have those features of damage, especially when we're talking about chronic vessel wall damage, as it would be if a large vessel is affected. So some pearls, again, I can't emphasize that enough. I think deeper levels are very useful, and I guess the other thing to keep in mind that there's some results that we have on our nerve biopsies that do warrant an early call to the clinicians when we get the H&E sections back, and before we have the final results that need the EPON sections that often take several days before they are ready for review. The next case is a 20-year-old that presented with a history of polyneuropathy and myopathy. And this is a nerve biopsy. So at low power, again, we see cross-sectional profiles of nerve with several fascicles. And I think even at this magnification, you already start to maybe see that there are potentially some infiltrates within some of these fascicles. So inflammatory infiltrates in distribution different than those that we saw in the last 2 cases, no longer epineurial and perivascular inflammatory cells, but endoneural inflammatory cells that almost produce these somewhat like plaque-like lesions. And if we zoom in a bit closer, we see that these infiltrates are comprised of chronic inflammatory cells, including lymphocytes, as well as some histiocytic cells, resulting in a somewhat nodular appearance to suggest that this might be some granulomatous inflammatory process. Down here is another focus. It's a bit more pale as far as the staining goes. So we have these multifocal areas of granulomatous inflammation in the nerves. These are the still images that just summarize those same features again. The granulomatous inflammation. These are the STEMAT and EPON sections of this case. At low power, maybe we could say that there's a mild decrease in the density of the large-minded axons. I'd argue that it's fairly uniform the way it affects the different fascicles. When we look closer, we see that the same inflammatory cell infiltrate that we saw on the H&E stain slides are also seen here on the EPON sections. That's another thing that I always feel like I like to emphasize. at least personally, often pick up the e-bond section and I feel like I'm very task-oriented. I look at the slide and I want to see whether the density of axons is preserved, whether there's any damage to the myelin. And I always have to remind myself to also pay attention to the vessels on the e-bond sections. I have to remind myself to look for any possible inflammatory changes, because once in a while, the e-bond sections may be the only preparation that you have where these features are present. And it would obviously be embarrassing in poor practice if I missed inflammatory changes that were only present on the e-bond sections and not seen on the paraffin sections. If you look around further, we also see that there are some axons that show some unraveling of the myelin sheaths that suggest that there's some ongoing axonal degeneration in addition to the presence of some axonal loss. So the peripheral nerves that we reviewed has granulomatous inflammation. The patient had a skeletal muscle at this biopsy at the same time that also showed granulomatous inflammation. This inflammation goes along with axonal loss and ongoing axonal degeneration. The organism stains were negative. And so the conclusion was that these findings are at least worrisome for a diagnosis of sarcoidosis. Sarcoidosis can affect peripheral nerves, and it's the one disease that I'm kind of discussing as an example of systemic inflammatory diseases affecting peripheral nerves outside those that cause frank vasculitis. About 1% of patients with sarcoidosis have peripheral neuropathy, and on some occasions, sarcoid neuropathy can be the initial clinical presenting features. The presentation can, on the clinical side, be heterogeneous. Sometimes as a side note, you can have vasculitis-like changes in the patient that have nerve involvement by sarcoidosis. I won't emphasize it otherwise, but there's some bits of data in the literature where people argue that some of the diagnosis for which people order a nerve biopsy may benefit from doing a skeletal muscle biopsy at the same time. And the diagnostic yield is improved if you do both biopsies at the same time. Sarcoidosis would be an example where people have argued that that's the case. Amyloidosis would maybe be another example, and vasculitis a third one. A fourth case is a 55-year-old that presented with orthostatic hypotension, nausea, vomiting, and length-dependent axonal sensory motor neuropathy. And this is the nerve biopsy that we got. A relatively thin nerve, looks a bit different than our typical cross-sectional profile of the sural nerve. So maybe it wasn't the sural nerve itself, but maybe a more distal nerve branch or a more superficial nerve branch that the surgeon did it for us. At low power, contrast to the last cases, we don't see any cellular infiltrates. But when you look a little bit closer, I think everybody can appreciate that there are these eosinophilic, glassy, amorphous deposits, partly seem to be centered around blood vessels, sometimes a bit more subtle, sometimes a bit more prominent. And I think reminders of what we expect to find in somebody who has amyloidosis with amyloid deposits in the tissue. These are the still images that illustrate these same findings. Again, we see these amorphous glassy deposits that look like amyloid on the H&E, and we can obviously then confirm that by doing the Congo red stain. As an additional step to doing the Congo red stain and looking at a polarized light, I also still like to look at the Congo red stains and IF scope. I find that sometimes helps me to make the stain a somewhat more sensitive and specific test, especially in cases where the amyloid deposits are maybe more subtle or equivocal than in this particular case. These are the EPON sections for this case. Again, I could argue that maybe the density of the large-minded axons is mildly decreased, and can see the same amyloid deposits here on the EPON sections. That is kind of somewhat smooth, glassy, amorphous, and anuclear deposits within the tissue. So our diagnosis for this case would be that this is a peripheral nerve with amyloid deposits and axonal loss. Subsequently, the patient was found to have monoclonal IgA lambda. And so when we take a step back and think about amyloid neuropathy more generally, most of the cases fall into these two groups, either related to light chain disease or to transthyretin amyloidosis. The phenotypic, the clinical presentation can be very variable. And I think amyloid neuropathy is probably one of the diagnoses that maybe more often shows up unexpectedly in patients that were initially thought to suffer from a different type of peripheral nerve biopsy. Amyloid deposits can be focal, so some people have argued that it's worthwhile to consider serial sections or serial congruent stain sections if there is a strong clinical suspicion for amyloidosis. And we can find the amyloid in different compartments. It can be epineurial, it can be endoneurial, it can be vascular, it can appear as being more in the soft tissues as just blobby deposits. In those cases where clinical tests and maybe special stains don't clearly define what the underlying type of amyloid is, one could consider doing mass spectrometry, since the amyloid typing nowadays becomes more and more important for the clinicians also that decide on how to best treat the patient next. So I think many people do integrate that the same way we do here. I would consider to do a congruent stain on every nerve biopsy. I feel like that I at least would otherwise easily miss cases where the amyloid deposits are more subtle. And yeah, at least from personal experience, I also think that it can be worthwhile to take the time and look at the congruent stain on the IF scope just to kind of confirm the conclusion that I arrive at by looking at the stain at the routine light microscopic level. The next case is that of a 55-year-old who presented with subacute ascending weakness and some numbness that evolved over a relatively short time period, over 2 weeks. He had some flu-like symptoms, and as you can guess by this presentation, initially he was thought to potentially have Guillain-Barré, some acute inflammatory demyelinating polyneuropathy. He was put on treatment. He didn't immediately respond, and as part of his workup, then still relatively early on, he had a peripheral nerve biopsy, and that's what I'm showing here. So the nerve biopsy that on some levels looks almost entirely normal. We see several fascicles here. I'll show you the EPON sections in a minute. When we look closer, again, not really any inflammatory cell infiltrates, any other significant changes. When you zoom in though, and in a compartment where maybe we usually don't even look as closely, we start to see that there are some of these larger cells within the lumen of some of these vessels. Here's probably one of the better foci. Here's just a single larger cell. This vessel here, the cells are a bit crushed, but you can kind of guess that there are probably similar cells in the lumen of this vessel as well as this vessel. These are the still images for this case that again looks in some areas relatively unremarkable, that has relatively good preservation of the density of large myelinated axons on the EPON sections, but then has these distinct large cells within the lumina of vessels. Those large cells stain for PAX5 as shown here. They were also positive for the CD20. So this was an example of lymphoma affecting peripheral nerve. And in this particular case, an intravascular large B-cell lymphoma. This patient passed away within weeks, and that autopsy showed involvement of brain, lungs, heart, as well as other organs by the intravascular large B-cell lymphoma. Kind of a continuation of this case still, I include this next slide. This was another nerve biopsy where even at low power, we see there's a dense cellular blue infiltrates. And if we zoom in closer, we see how these are located both in the epineural as well as in the endoneural compartment, seem to be comprised of these dense aggregates of lymphocytes. This was a case of peripheral nerve involvement by B-cell lymphoma, maybe a bit more of a typical example than the first one for what you might encounter if you have lymphoma affecting the peripheral nerves. Another still image here, and this is the CD20. Again, the cells are virtually all positive. On this particular case, these are the EPON sections that show that there is dropout of large myelinated axons here with a decreased density. And in addition, again, as already pointed out earlier, we do see involvement by the same cellular infiltrates that are seen on the paraffin sections here in the EPON tissue. So neurolymphomatosis, or lymphoma involving nerves, basically a presentation as the result of neoplastic infiltration of peripheral nerves by usually non-Hodgkin lymphoma. I feel like the question comes up maybe more often than we see it. The presentation can be heterogeneous in rare instances, and a bit maybe that is the case in the first case of the lymphoma here that I showed. The neuropathy can be the initial presentation for the patient that has lymphoma. And I think it's important to keep this in mind, and the next case will illustrate that clonality studies are very helpful in distinguishing these cases of lymphoma involving peripheral nerve from other disease processes. So I already mentioned this several times, but I feel like it's a good reminder to always remember to look at the EPON sections for other features beyond just changes in the axon morphology, the distribution of the myelin throughout the nerve, and look specifically whether there are any cellular infiltrates, whether there are any vascular changes. This is case 6. This is a patient that was 44 years old and started to have paresthesias in the lateral foot. The symptoms started to spread to involve the other side. On an EMG, he had features of an axonal polyneuropathy involving sensory more than motor function. And when you look at this H&E, could say it looks a bit similar to the last case that I showed you. There are these dense cellular infiltrates, dense clusters of lymphocytes, both in the epineural as well as in the endoneural compartment. So the still images for this case here. And it seemed like the lymphocytes were mostly positive for CD20. So this is an EPON section that shows that there's significant dropout of the large myelinated axon that goes along with these lymphoid infiltrates. And yeah, I'm sure it doesn't happen to other people, but this is one of those cases where I was wrong with my initial impression. I thought that this was worrisome for involvement of the nerve by a B-cell lymphoma. We ordered the molecular studies, but I was kind of happy to somewhat move on to the next case in line and forget about this. But it turned out the molecular studies were negative for any clonal alterations. And when we go back to this case, we see that there are dense infiltrates by CD68 positive histiocytes, especially in those areas not involved by the lymphoid infiltrates. And as you might guess at this point already, this is the AFB stain, and you see that there are abundant organisms here. this is a phyte stain. The contrast here is not as good as on the AFB stain, but we do see these reddish organisms here in the background, also on the phyte stain. Can even find them on the electron microscopic studies. So this turned out to actually be a case of lepromatous leprosy, with the organism stains being positive. And we also sent a tissue off for PCR-based testing to confirm the presence of the organisms. So the patient, after the biopsy, then had a detailed skin exam by a dermatologist. They did not find any other lesions to suggest that clinically this would fit for what's described as a purely neuritic form of leprosy. There were no granulomas to appreciate, and at least for me, this biopsy initially mimicked involvement of a nerve by a B-cell lymphoma, especially with the predominance of the B cells based on the IHC stains. Pure neuritic leprosy accounts to 4 to 8% of the cases of leprosy. The acid-fast bacilli you have present are typically seen either within foam cells and Schwann cells within the nerve tissue. And I guess broadly speaking, there are these two forms in which we see leprosy-involved tissues. In the lepromatous forms, we have numerous organisms, but typically no good formation of granulomas. And so that's why this nerve biopsy would fit for that diagnosis. In the tuberculate form of leprosy, we see granulomatous inflammation, but usually at most scanned organisms. And especially then in that setting, the PCR testing is very helpful to help confirm the diagnosis, because it's difficult to rely on just the organism stains to rule that diagnosis out. That's one other comment. I guess this patient, it turned out, did have travels to the Indian subcontinent, but his last trip dated back some 8 years prior to the biopsy. And I think that's also an educational point to keep in mind, that leprosy can be seen even for us here in the US, even though it's not common. And I guess the other learning point for me was to not just always make that association between leprosy and granulomas, because in cases like this, or like this case illustrates, you can have cases of leprosy where you don't have the granulomas as a features as a clue to the diagnosis. The last case I wanted to share with you is this of a 9-year-old girl that was born with a term, had unremarkable early motor milestones. But then after a few years, her parents thought that she was a bit more clumsy than expected. At age 6, she had a bit more of a formal exam. She was found to have generalized hypotonia, had foot deformities, had weakness and dorsiflexion of the feet and inversion of the feet. Sensation for vibration seemed to be decreased. And an EMG then showed that she had an axonal neuropathy. I have to admit, I'm not entirely sure why the clinicians ordered this nerve biopsy. They already had a genetically confirmed diagnosis at this time. But we did get biopsies of kind of thin cutaneous nerve branches. Going along with that, we see that the cross-sectional profiles we have here basically just always show it like 1 or 2 fascicles. But despite that limitation, we see clear abnormalities. If you look around here, we see what appears as normal axons in the background, and then we see these large, swollen, uniform pinkish structures that form these almost ball-like structures. Those, at least we could imagine, being large, swollen axons. They were positive on the neurofilament stain. These are just the still images again to recap those findings here. I have some electron micrographs to show. So here we see kind of a more normal axon for comparison, and then this large axon here that lacks any myelin. Some of these large swollen axons did have a myelin layer, as we see in this example here. And so this nerve biopsy went along with what the genetic diagnosis was that the child already had. That the child had giant axonal neuropathy. And so it's the one case that I'm showing as an example of inherited peripheral neuropathy involving peripheral nerves. These inherited diseases are kind of a large heterogeneous group. And at least in my practice, but I also think based on what the literature says and other practices, this is a group of diseases for which we probably see very few biopsies these days, in contrast to what the situation was like 15 or 20 years ago, because most of these patients now have genetic testing to establish the diagnosis. And so they usually have the genetic confirmation of the disease before the question of a biopsy even comes up. So I showed an example of giant axonal neuropathy as one example. Typical features we might look for a diagnosis of Charcot-Marie-Tooth disease would be, at least in some of the types of CMT, the presence of onion bulb formations where we kind of see this concentric wrapping of Schwann cells around an axon in the center. These onion bulbs you might see better on the semi-thin EPON sections as illustrated here. See them by electron microscopic studies. And if you were to do the teeth fiber preparation in cases like this, you'd be able to show that you have the normal thick and long internodes here that are then segmentally replaced by abnormally thin and short internodes to suggest that there's segmental damage to the myelin that would also go along with the demyelinating disease process, such as in the demyelinating forms of Charcot-Marie-Tooth disease. In hereditary neuropathy with pressure palsies, we get these sausage-like dilatations or expansion of the myelin around axons, so these tomaculi as the diagnostic features. Again, I think that's a disease process for which usually the clinical history already makes the diagnosis. And if there's any question, then usually the clinicians order the molecular testing to confirm that diagnosis. And I haven't seen a nerve biopsy taken with this question in mind for a long time. Then we can see involvement of peripheral nerves by different types of storage diseases or leukodystrophies. These are just some electron micrographic images of lysosomal debris in a patient that was known to have Fabry's disease at the time the biopsy was done. Lastly, just to mention this, something it's maybe sometimes a bit harder to interpret on the nerve biopsy. Sometimes in the peripheral nerve biopsy, we see these polyglucosame bodies that can show up either on the H&E stain section. So we see several here on the semi-thin EPON sections from this case. Theoretically, their presence could raise the question of adult polyglucosame body disease. But you can also find these as what probably an incidental aging change in patients. And so I think it's hard to know just based on looking at the nerve biopsy what the significance of this finding is when you see it without having details of the clinical history. So it's something that I maybe mentioned the comment as something that the clinicians have to correlate with the history. And if the patient doesn't even have a presentation that would fit for this disease process with gait disturbances, neurogenic bladder type findings, maybe even some CNS type cognitive changes, and yes, the clinicians can do the genetic testing to rule that diagnosis in or out. So again, there's a number of hereditary diseases that altogether are not even that uncommon as a cause of peripheral neuropathy. But I think usually now the clinicians address these early on before they even start thinking about a peripheral nerve biopsy as a diagnostic tool. So just as a brief summary, peripheral nerve biopsies are done by the clinicians usually when there's a subacute progressive presentation with cryptogenic neuropathy. Common questions that might come and lead to the submission would be, is there vasculitis, is there amyloid? If there is vasculitis in the nerve biopsy, it's good to make sure that the findings fulfill the criteria that have been proposed, and then to kind of try to distinguish whether the findings fit more for large vessel involvement to suggest a systemic vasculitis, or whether it's more the small vessels that are affected to suggest that it may be a non-systemic vasculitic neuropathy. And then sometimes we see more unusual changes. It may be distinctive, may suggest a specific diagnosis. And so I think even though they are unusual, it's good to kind of be aware of these changes, so to be able to follow up these up appropriately with special stains or studies as necessary. So, thank you.
Thank you, Peter. Those are beautiful cases. So it looks like we have 3 questions in the chat box. If it's okay, I'll go ahead and read the first one.
Sure.
So Mark Cohen asks, do you ever use IHC to assess distribution of axonal loss? If so, do you have a favorite? NF, CD56, PGP 9.5? Thanks.
I have not really used IHC staining for the axonal loss. As a marker that I sometimes do, maybe for somewhat similar reason, is a CD68. I feel like sometimes, even with the EPON sections in hand, one might go back and forth about whether changes to the myelin morphology are artifactual or real. And so if I find increased CD68 staining in the endoneural compartment, I find it sometimes a somewhat helpful feature.
Okay. And then Michael Farrell asks, do you have a view on skin biopsy for assessment of small sensory fibers?
We don't do that test here. Our clinicians send it out to one of the commercial laboratories.
Okay.
I try not to form an opinion on that.
Okay.
Yeah, I don't really know how useful it is, but the clinicians always seem to be so excited about it, and so I'm not so sure. Yeah.
Okay. And then the last question, Murat Goktan, thanks for this nice review, Peter. How often do you utilize EM and how far do you take it? For example, in terms of demyelination, basal membrane thickness evaluation, unmyelinated fiber evaluation, etc.
If I had to guess, then maybe I'd say that I probably do EM in about maybe 10% of the cases that I see. I think most of the time I use it more as a tool to confirm things that I'm suspecting, but where I'm not sure enough based on the EPON section. So that could be, for example, whether changes to the myelin morphology are artifactual or not. Sometimes I find the EM can be helpful for me. Sometimes if I want to look at microvascular changes, I do the EM. I don't usually make any detailed comments about demyelinating features because I usually look at the EM sections and cross sections. So unless I see kind of more acute changes, I'm not sure how reliable my EM exam would be to distinguish demyelinating features from regenerative changes in the context of axonal loss. And yeah, I usually don't make any specific comments about the unmyelinated axons on the EM. I feel like I would have to look at more cases to make that a more reliable test in my hand.
Okay. There is one more question. I don't know if we have time. I'll just read it. Emily Sloan, how often do you use nerve tease as a supplement to the other evaluations?
Yeah, I feel like it's probably a somewhat controversial topic, and so different people will give you different answers. I essentially never use it anymore. That maybe also has institutional reasons. I think once you fall below doing a certain number of these cases, it becomes hard because the technicians lose their expertise of doing it appropriately. But for us, it just wasn't worthwhile continuing this because became less and less frequent that the clinicians asked for it or thought it to be useful. So we stopped doing it.
Okay. And then you got one more thank you very much from Murat, and I think we're at 1 o'clock. So thank you, everybody. And
Thank you,
for
Dr.
the-
Oviedo. Thank you again for
Thanks.
joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Pytel for an excellent presentation. This concludes the session for today.